You probably want to give it a couple minutes for people to come in.
Yeah.
So they see the email address.
We'll start at 8:03, more or less. So I'm recording, right? Yeah, I think.
Yeah, it says recording.
Okay, well. Okay, let's see. Okay, we will start. Good morning, everyone. Thank you so much for joining our MSK Visiting Professor e-lecture series. Today we have one of our own colleagues, superstar Courtney Gleason from the Department of Orthopedics here at Emory Sports Medicine. Before we begin, we're just going to touch bases on a few pointers. This is a part of the MSK Education, a Visiting Professor e-lecture series. This webinar series is meant for educational purposes only. All interactive features for attendees have been disabled to ensure optimal quality of all viewers. Please email questions to Emory MSK Radiology at gmail.com. Give you a second here to write down the email address. Again, Emory MSK Radiology at gmail.com. At the very end, the speaker has graciously agreed to answer questions in a Q&A session that will take about 10 minutes or so of her time. This video is being recorded. It will be available in the YouTube channel of Emory MSK Radiology. So if you go to YouTube and you search for Emory MSK Radiology, you'll see the YouTube channel there. This presentation will be available today within a few hours on demand, free of charge to everyone. Attendees have not been given permission to screen record any of these talks, which may contain material on the copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. This webinar series is brought to you by the Musculoskeletal Imaging Division at Emory University. So our speaker today is Courtney Gleason. Courtney Gleason, it's a pleasure to have her here with us today to speak to us about a very important topic. Dr. Gleason is a non-operative sports medicine physician at Emory University in the Department of Orthopedics. She holds an undergraduate degree in biological sciences from the University of Notre Dame and her medical degree from the University of South Carolina. She completed 3 years of an orthopedic surgery residency before moving to Atlanta and completing a pediatric residency at Emory. She did a non-operative sports medicine fellowship at Harvard at Boston Children's Hospital. Before joining the faculty at Emory, she was an attending physician at Brown University in Providence, Rhode Island, and she was one of the team physicians for Brown Athletics. At Emory, she is the director for Emory's Female Athlete Program. She's the head team physician for Agnes Sky College and a team physician for the Atlanta Dream. She's also serves as a physician for the Atlanta Ballet. While training in Boston, she worked as a company physician for the Boston Ballet, and in Providence, worked with the dancers from Festival Ballet. She has traveled internationally with the U.S. Soccer and has served as a crew chief for the Peachtree Road Race for the last 3 years. She enjoys treating athletes of all ages, sports, and skill set level. Special interests include working with dancers and aesthetic athletes and runners. She's particularly interested in bone health. Her presentation will focus on that today. Bone stress injuries, overuse injuries, and the concept of relative energy deficiency in sport. She has a special interest in understanding female athlete attrition in sports and working with and for female athletes to optimize performance, minimize injury risk, and keep them active playing the sports they love. She's a member of the American Medical Society of Sports Medicine, the American College of Sports Medicine, the International Association for Dance Medicine and Science, Pediatric Research and Sports Medicine Society, and Alpha Omega Alpha Medical Honor Society. So it is my honor to introduce my friend, my colleague, Courtney Gleason. So Courtney, we'll transition here to you.
Thank you so much, Felix. And is my screen being shared?
Not yet, you have to
No.
share.
Okay. And then am I able to start my video, or am I just doing the screen? Okay.
You have to start your video. Yeah.
Okay.
Let me know if you cannot share your screen. Okay, there you go.
Okay.
Perfect.
All right, perfect. Felix, thank you so much for the introduction, and thank you to all of my colleagues within the radiology department for inviting me to be a part of this today. I've really been looking forward to this. Today, I'm going to talk on a topic that is of particular interest to me, and that is bone health and its interrelatedness with the concept of relative energy deficiency in sports. I have no disclosures. And I wanted to start with a case presentation. So this is a woman that I saw in clinic, a 27-year-old female runner who presented in clinic with left hip pain. When she came in, she'd been training for 2 months for a marathon, and she reported a 10-day history of left hip pain localizing to the groin area. She initially had pain with running, and then it had progressed to pain with walking, and she hadn't been able to run for about the last 5 to 7 days because of increased pain with running. On exam, pertinent exam findings were that she reported pain when she was walking. She was able to walk with a non-antalgic gait, but reported pain. She was not able to do a single leg hop, secondary to pain. She had pain with passive log roll and extremely limited internal and external rotation, secondary to pain. So we got some imaging, and the pertinent findings are seen on this MRI. So she had compression-sided femoral neck stress fracture. And then on the axials, you can see the involvement, and she actually has a little involvement of the ischial tuberosity as well. So relevant history, she's on Sprintec for ovarian cysts. She reported no dietary restrictions except not eating fish. And we had an extensive conversation regarding this finding of the femoral neck stress injury, but she did not want further workup due to financial concerns. She did not want to go forward with labs or Dexa. So her clinical course, she was placed on crutches, protected weight bearing until she was no longer having pain with walking. She did subsequently heal the femoral neck stress injury, and she started a return to running program 4 months after the initial diagnosis. So she went on, and I didn't see her till about a year later when she presented to clinic again. She actually participated in the marathon she'd had to miss the year before because of the previous femoral neck stress injury. So as she was running the marathon, she reported that she had started to have foot pain at mile 14. She finished the race, and afterwards, the following day, she went to a local urgent care. She was diagnosed with this third metatarsal stress fracture, and she presented to clinic already in a walking boot. So at that point, she agreed to blood work, and she agreed to a Dexa, and she had a vitamin D. So kind of through the extensive blood work, the one pertinent finding was a vitamin D of 26, and she had what's considered a low bone mineral density for age, given her her status as an athlete, of the lumbar spine of -1.8 standard deviations Z-score from age and gender matched norms. So this clinical course, she successfully improved with vitamin D supplementation for 2 months, up to a level of 52. She is following with endocrinology, secondary to the diagnosis of low bone mineral density for age. The plan is for her to repeat the Dexa in a year. She's been consulting with a sports nutritionist, and she has successfully healed the third metatarsal stress fracture, and she is currently returned to running. So just to give some background of relative energy deficiency in sports, I always think it's interesting to kind of know about the history of a concept. And so the initial concept of relative energy deficiency in sports actually started as the female athlete triad. And really in medicine, this is a new recognized syndrome, first described in 1992 and officially defined just in 1997, so just over 20 years ago, by the Task Force on Women's Issues of the American College of Sports Medicine. This was a recognized syndrome observed in physically active girls and women with 3 distinct medical disorders, including disordered eating, amenorrhea, and osteoporosis. And in 2007, the ACSM changed the terminology, recognizing that there's an interrelatedness of these components between energy availability, menstrual function, and bone health. Recognizing that this is a spectrum that shows the interrelatedness, but also that there's a spectrum of pathology versus optimal health. So looking at these 3 components, optimal energy availability, progressing to low energy availability with or without disordered eating, optimal bone health to low bone mineral density and osteoporosis, and eumenorrhea and hormonal health, progressing to amenorrhea and functional hypothalamic amenorrhea. This schematic also shows not only the spectrum from optimal health to disease state, but also the interrelatedness of low energy availability of specifically affecting hormonal health specifically affecting bone health, and the concept of low energy availability specifically affecting bone health as well. So we see that poor nutrition is associated with low energy availability, and this can precipitate amenorrhea. And the amenorrhea can in turn lead to bone loss secondary to the low estrogen state. And then the poor nutrition with or without disordered eating can lead to osteoporosis or poor bone health through inadequate ingestion of calcium and vitamin D, and also inadequate overall caloric consumption. So then we move forward to 2014. The International Olympic Committee coined the phrase of relative energy deficiency in sports to emphasize that this syndrome affects all athletes and not just females. Certainly it affects males as well. And it also recognizes that insufficient calorie consumption to support the level of exercise energy expenditure compromises physiologic processes that go beyond just the bone and hormonal health. And it also incorporates the concept that low energy availability in sports can negatively affect the athlete's performance as well. So this is a schematic different from the model that we saw explaining female athlete triad. This schematic of relative energy deficiency in sports places the energy deficiency in the middle of the schematic, and off to the right you can see the components of the triad with hormonal health and bone health, but also the other physiologic processes that are now recognized to be affected by energy deficiency in sport. Endocrine effects, metabolic effects, hematologic effects, growth and development, psychological effects, cardiovascular, GI, immunological. Also important, and particularly important for athletes, and sometimes what gets their attention the most, is the potential effect of relative energy deficiency on sports when there's sustained decreased energy deficits. We know that athletes are at increased risk of injury, have a decreased training response, impaired judgment. They can experience decreased coordination and concentration, irritability, increased injury risk, decreased muscle strength, depression, decreased endurance performance. The concept of energy availability is really what underpins the female and male athlete triad and relative energy deficiency in sports. Energy availability is defined as the amount of energy left over for normal physiologic processes once energy required for an athlete's sport has been accounted for. This is goes to show the concept behind energy availability. What we know about it is it's actually a very hard thing to calculate. In athletics, I always work with a sports nutritionist when we're talking about energy availability and have concern that an athlete may be experiencing effects of low energy availability. The part that I always want to drive home with people is that there are a couple numbers to remember with this. So energy availability greater than 45 kcals per kilogram of fat for your body mass per day is recognized to support normal physiologic processes. And we start to see negative effects, including negative effects on metabolism, negative effects on reproduction, and disrupted bone metabolism less than 30 kcals per kilogram fat-free body mass. As I said, energy availability is a difficult thing to calculate. So when do we clinically suspect low energy availability? In adults, a BMI of less than 17.5 or a reported history of significant weight loss, really anytime. Oftentimes I'll ask 1 month, 3 months, 6 months over the last year. And in adolescents, we don't specifically use a specific BMI, but we use the BMI percentile method for calculating an estimated body weight. And so suspicions it should be increased for low energy availability when the BMI is less than 85% of expected body weight. Oftentimes for adolescents, the use of growth charts is helpful because with some athletes, they may not have lost a lot of enough weight to be below that 85 percentile, but they may have fallen off their growth curve, which can be an indication that they may be experiencing the effects of low energy availability. So going through the concept of relative energy deficiency and low energy availability, I want to kind of pick out that one piece of the bone health and focus a little bit more on that. Bone stress injuries are usually how I see these athletes present to clinics. So they don't come in saying, I have relative energy deficiency in sports. They come in with a bone stress injury. And that's typically how I see them. And so I'd like to delve a little bit more into that, that clinical picture. So bone stress injuries are overuse injuries caused by repetitive submaximal mechanical stress, which results in structural fatigue and abnormal bone remodeling. And we know that it's a continuum that starts with stress reactions and can progress to complete fracture. And bone stress injuries account for about up to 20% of overuse injuries in athletes. So it's super common. When an athlete comes in with a bone stress injury, it's important to kind of think about all the different risk factors that may be contributing. So intrinsic risk factors specific to the athlete, and then extrinsic risk factors. Some of the intrinsic risk factors for bone stress injuries, as we've just talked about with relative energy deficiency in sports, there's certainly the risk factor of sustained inadequate calorie consumption to support the level of physical activity. There's the concern for the possibility of a low estrogen state as we see with functional hypothalamic amenorrhea. Genetics plays a role, biomechanics, leg length discrepancies. If they have pes planus or pes cavus, their lower leg alignment, muscle weakness and tightness. And some of the extrinsic risk factors that we recognize are sustained excess mileage or hours of training, ramping up mileage or hours of training too quickly. Training surface certainly does play a role as well, poor technique, and other things like smoking and alcohol consumption. We know that bone remodeling is a dynamic process and relates to the interplay of two opposing signals, those of the osteoblasts and osteoclasts, with bone formation and bone resorption. We also know that estrogen is necessary for the building of bone. So in these female athletes, when they come in with low estrogen secondary to functional hypothalamic amenorrhea, we know that bone loss occurs because bone growth is decreased while the bone resorption continues. And we know that these athletes are at risk for bone stress injuries as a result. So when I'm seeing athletes in clinic, who's at risk for energy deficiency and developing these injuries? Certainly, initially, there was a lot of focus on athletes who participate in weight-sensitive sports, in which leanness and body weight are important, maybe for performance, like cross-country running and cycling, appearance with gymnastics, dancing, cheerleading, or if there's a sport such as wrestling, rowing, or martial arts where there may be a weight category. However, we know now, over the last several years of working with athletes, that the index of suspicion for relative energy deficiency in sports is really can potentially affect any athlete in all types of sports. In 2007, there was a study looking at 671 stress fractures in collegiate student athletes, and the highest rate of stress fractures were seen in women's cross country, followed by women's gymnastics and women's outdoor track. In this particular study, metatarsals were the most common location, followed by the tibia. This particular study, about 38% were metatarsal stress fractures and the tibia 22%. Looking through other numbers, though, in other studies, you'll find a little flip where the tibia is actually considered the most common site of bone stress injury. Metatarsals about 9%, and then femoral neck about 11%. But depending on the study you're looking at, you'll get little numbers changes, but these are commonly involved areas. The fibula can be commonly involved, and really the most common site of a bone stress injury varies from sport to sport. So in a soccer player, you may see a base of the 5th metatarsal fracture more commonly than you do versus a runner with a tibia or a metatarsal stress fracture. As we mentioned before, bone stress injuries account for up to 20% of overuse injuries in athletes. Looking at a couple different studies and incidence of bone stress injuries among female athletes, one study from last year found that number to be about 13%. Another study looking at the 1-year incidence in cross country and track and field athletes found the incidence between 5 and 20%. In 2012, another study found that 27% of female endurance athletes had previous diagnosis of a stress fracture. And this study actually brought in some of those other components of the triad in relative energy deficiency in sport, looking at the prevalence of menstrual dysfunction or hormonal dysregulation, and found that athletes with a history of menstrual dysfunction had a statistically higher rate of stress fractures. They also found other independent predictors, including compulsive exercise, amenorrhea, and lower leg lean tissue mass. In 2015, Ackerman did a study looking at 175 females between the ages of 14 and 25. In her study, she found 39% of amenorrheic athletes had a history of stress fracture versus about 6% of eumenorrheic athletes with a history of stress fracture. So statistically greater incidence of stress fracture in the amenorrheic compared to eumenorrheic athletes. Studies show that for athletes with a single triad finding, the risk of stress fracture is about 15 to 20%, and that increases to 30 to 50% with multiple aspects of the triad. So why is this important? Well, certainly bone health itself is important, but sometimes trying to get through to athletes talking about time out from sport can really get their attention. With bone stress injuries, time out from sport depends on the grade and extent of injury and which bone is involved. Oftentimes it'll be 6 weeks, 12 weeks, sometimes longer, and that's really just the beginning of when they can kind of get back to running or get back to dance or get back to the high impact training. This is a table just listing some of the low and high risk bone stress injuries and their locations. So lower risk stress injuries include the posterior medial tibia, the fibula, femoral shaft, calcaneus, and the 2nd, 3rd, 4th metatarsals, diaphyseal fractures. Higher risk locations include femoral neck stress fractures, anterior cortex of the tibia, the medial malleolus, talus, navicular, the base of the 5th metatarsal, base of the 2nd, metatarsal. So oftentimes we use some of the radiology findings to help talk with athletes about how long to expect to be out, although there's not an absolute value to say, you have this MRI finding, so you'll be back in 3 weeks or you'll be back in 6, but just to kind of give us an idea, a time frame more than anything. So in looking at the classification system that we commonly see with tibial bone stress injuries, the grade 1 stress injuries, usually it's about 3 weeks out and then starting back with a return to higher impact over a gradual period of time. For grades 2 and 3, I usually talk with athletes to expect about 6 weeks, but it can be longer. And then grade 4 up to 12 weeks, possibly longer, before they're back to starting back. It's always important and helpful to talk with athletes that when they're getting back, when they hear 12 weeks, they think at 12 weeks, I'm going to be, back to running 40 miles a week or back to dancing 20 hours a week. And so it's important to kind of set their expectation that 12 week is just the time frame that they're going to start gradually getting back. But if we, arrive at 12 weeks and put them back out running on asphalt for 40 miles a week again without appropriately increasing, then we'll just find ourselves right back where we were. With femoral neck stress fractures, there are various classification systems, but oftentimes in sports, we're looking at these more from a compression-sided stress fracture versus a tension-sided stress fracture. With compression-sided stress fractures, we oftentimes treat these non-operatively, usually on crutches for a period of time until they're not having pain when they're walking. And usually it's about 12 weeks or longer that they're out from high impact activity. For tension-sided stress fractures, these are typically being sent for a surgical consultation. This is a study that we talked about just a little while ago, the study from 2017. And I wanted to highlight another finding from the study, and that being that 21 to 22% of stress fractures are recurrent injuries. And so when you really think about the time out from sport, if it's 6 weeks, 12 weeks out from sport, and then they're getting a recurrent injury, it's a lot of time that athletes are missing because of these stress injuries. So if we can really understand the underlying risk factors and address some of those, that really helps athletes stay in their sport. And the study also found that 20 to 21% of stress fractures were season-ending injuries. So again, these are actually pretty significant injuries. There's a high rate of recurrent injury. And then the season-ending component, where about a fifth of athletes with a stress fracture, it's happening at the optimal time at the end of their season when they're having, important races or competitions, and they are out for those. Relating to these injuries. In addition to the acute stress injury, there's also the risk of osteoporosis long-term. So we know that peak bone mass accrual occurs principally during puberty, and by mid-20s, young women have reached about 99% of their total bone mineral content. So poor nutrition and estrogen deficiency during this critical window for female athletes can put them at risk for increase of low bone mineral density and osteoporosis later in life. This is really the time where it's determined whether they'll reach their genetic potential for bone mineral density. So when I see an athlete come in with a bone stress injury, I go through very extensive questioning, again, trying to identify some of the risk factors that may be playing a role, with a large component to the different aspects of relative energy deficiency in sports, but also wanting to make sure that there aren't other things that need to be recognized that may significantly be impacting and putting them at risk for these injuries. So I go through an extensive kind of energy history, dieting history, weight fluctuations, highest weight, lowest weight, special kind of food restrictions. Are there food groups that are avoided? Or hormonal health history relating to age at first menses, how many menses in the last 12 months, A history of currently taking contraception is super helpful because that changes interpretation of some of these answers. And then a bone health history. So history of stress fracture, history of low bone mineral density, other fracture history. Go through an extensive medical history, celiac or other digestion problems, history of thyroid, other autoimmune diagnoses. List of medications is super important, long-term steroid use, other medicines that could potentially predispose to low bone mineral density. Are they taking, or what's their calcium, vitamin D intake? Family history, including focus on kind of osteoporosis that's affected family members younger than 50 years of age, or male family members with a history of osteoporosis, hip fractures, thyroid, parathyroid disease, other autoimmune disease. And then that training history. So those extrinsic factors, what is their training routine? What's their mileage like in a week? How many hours are they dancing? How many hours are they practicing? Are they taking rest days? Do they cross train? What's the surface like? Running shoes, orthotics, all of these things can play a significant role. This is an extensive list of some of the labs and diagnostic tests that can be helpful in understanding an athlete's risk or underlying contributing factors to a bone stress injury. Certainly, I do not get all of these labs on every patient who comes in with a bone stress injury, and some of these labs are done by other specialists with whom I work in sort of a multidisciplinary approach. But there are some specific screening labs that I'll look at for athletes who have bone stress injury. Things like CBC, I'll look at a ferritin, vitamin D level, I'll look at electrolytes often, calcium, thyroid panel is super helpful. And then oftentimes we'll look at some just initial hormone levels, estrogen, progesterone, estrogen, FSH, and LSH, or LH are some of the initial ones that I'll look at, just depending on what their history and what's potential suspicions there might be. When do we get a Dexa? So these are just some guidelines that can be helpful. An athlete who comes in who has a high risk, one high risk factor, a history of an eating disorder, and a lot of this is going to be determined by kind of what the setting is for the athlete. Are they a collegiate athlete or a professional athlete or a recreational athlete? But one high risk factor can be a reason to get a Dexa in the right setting. So history of a diagnosed eating disorder, a BMI of less than 17.5 or less than 85% estimated body weight. If they've had a significant recent weight loss, greater than 10% in a month. If their age at first menses was 16 years or older, if they've had less than 6 menses in the last 12 months, history of 2 prior stress fractures or 1 from that high risk stress category, or a prior recognition of low bone mineral density with a Z-score of less than 2. And I should have mentioned this before, but when we're talking about premenopausal women, we always use the Z-score when we're talking about bone mineral density, as the Z-score actually compares the bone mineral density for that particular athlete to other individuals' age and gender match norms, versus the T-score is comparing the bone mineral density to young bone mineral density of 20-year-old. And so the Z-score kind of gives you something more specific to that particular age group and that gender. And then another reason to get a Dexa would be greater than 2 moderate risk factors. So a history of disordered eating, so maybe not a diagnosed eating disorder, but a history of disordered eating for greater than 6 months. A BMI between 17.5 and 18.5, or less than 90% estimated body weight, a recent weight loss of 5 to 10% in the last month, first menses between 15 and 16 years old, and in the last 12 months, 6 to 8 menses. And then the prior low bone mineral density Z-score between -1 and -2. When we get a Dexa, it's important to kind of think about the age of the athlete. For premenopausal women greater than 20 years, usually you're looking at weight-bearing sites, the lumbar spine, total hip, and then specifically the femoral neck. For athletes and adolescents less than 20, it's usually whole body, less head. And so I usually send these athletes over to Children's to do their bone density there. So talking about low bone mineral density, we talked about this a little bit a few slides ago, but we look at the Z-score for these athletes who are premenopausal, and we consider low bone mineral density less than -2 standard deviations from adjusted age match and gender match norms. However, when we're talking about weight-bearing athletes, it's recognized that exercise and physical activity should actually positively influence bone mineral density. So actually in weight-bearing athletes, we consider it low bone mineral density if they have a bone mineral density of less than 1 standard deviation from the age and gender match norms. And this is the recognition that in kind of hormonally replete athletes, they typically actually have a bone mineral density that's 5 to 15% better than sedentary controls. And then the actual diagnosis of osteoporosis requires a clinically significant fracture history along with the diagnosis of a low bone mineral density. So when thinking about relative energy deficiency in sports, we talked specifically about treatment for bone stress injuries, kind of length of time out from sport, but it's also super important to address potential other risk factors, including if there is a component of relative energy deficiency in sports. So if there is an energy deficit component, then treatment focuses on restoration and normalization of body weight, which is really the best strategy for resumption of menses and improving bone health. Recommendations include an increase in energy and dietary energy intake, and sometimes also a decrease in exercise energy expenditure. So thinking about these interrelated components, so energy availability, hormonal health, and bone mineral density, it's helpful to kind of have an idea of the spectrum of kind of length of time it takes for these entities to respond. So physiologically, the body responds to energy deficits within, days to weeks, but also with energy restoration, the body also responds quickly. So you start to see changes relating to energy availability within days to weeks once this is recognized and the education is provided. With hormonal health, prolonged states of energy deficit, it can take months for that to affect the hormonal health in an athlete. And similarly, it can also take a few months for hormonal health to normalize once there's been energy restoration. The important part talking about bone mineral density is that the deleterious effect of low energy availability, sometimes it's not recognized for a long time. It can take a long time for that to become clinically apparent. Even up to years, an athlete can be in a low energy state without having recognized effects on the bone, meaning coming in with bone stress injury. And in that, it can take a long time for improvement of bone mineral density after there's energy repletion. And again, this is important just because that critical window in an athlete's life during the adolescent and early 20s kind of to maximize bone mineral density going forward. So usually when we're thinking about, when we're talking about weight and energy restoration, I'm always working with a sports nutritionist. And so the goal is to kind of think about that BMI of 18.5 or greater than 90% of ideal body weight. Sometimes, depending on where the athlete is in their season, maybe a modest exercise reduction in addition to the caloric intake. But again, this can be dependent on where are they in the season. Is it possible to reduce the exercise, or is it mostly that we need to focus on the weight gain as the best strategy, particular to where they are at that particular time? The best case scenario is that treating energy deficits is just a matter of education. For example, an athlete wants to kind of be their best, and so they, have developed sort of ideas that avoiding carbohydrates or eating mostly a plant-based diet is going to help them be their best. And in those cases, it may just be an educational piece to talk about the importance of nutrition and not restricting food groups. And in those cases, athletes are very amenable to making the changes once they have the education piece. There can also be, in the idea of disordered eating, there can also be a mental health component to it for some athletes and may require the participation of a mental health specialist in some instances. But in the ideal circumstance, kind of providing that education to the athlete about energy requirements, needs for calcium and vitamin D can be super helpful. And for these athletes, the education goes a long way. I just put this in here just to mention, when we talk about relative energy deficiency in sports, people talk about oral contraceptive versus transdermal estrogen. And again, usually in a multidisciplinary approach, I'm working with an OB/GYN or an endocrinologist who would oversee implementation, specifically looking at estrogen affecting the bone density. There have been some initial studies looking at transdermal estrogen actually having more of an impact just because of its metabolism through the liver and how that's metabolized versus the oral route. And then there's also discussion about bisphosphonates. So huge kind of word of warning here, always only in discussion with an endocrinologist, as in women of childbearing age. This usually you would avoid this completely. So thinking about when do we return an athlete to play, are they eligible to play, or when can we return them to play? When we're talking specifically about relative energy deficiency in sports. And this can be a little tricky, only because we don't have a validated assessment tool yet to say, this athlete for sure falls into this kind of risk category or not. And so these are some of the different screening tools that are available. And then you can kind of categorize high risk, moderate risk, low risk. But one of the tools that can be helpful and a little bit more straightforward for specific athletes, specifically with collegiate athletes where you're doing their pre-participation evaluation, and you can kind of categorize them into different low, moderate, and high risk, looking at their history of low energy availability, low BMI, age at first menses, any history of oligomenorrhea or amenorrhea, low bone mineral density, and stress fracture or stress reaction. So going through this, you can kind of identify those athletes who may be at higher risk. And this is not, this is not the final decision maker, but as you categorize those athletes based on those risk stratification categories, it can help you to know who do you need to keep a really close eye on throughout the season. There may be some athletes who medically really shouldn't be participating. And so I found this to be a helpful way to kind of help categorize and understand risk related to specific athletes. Going through all of this, one of the biggest, well, the biggest take-home point is when treating athletes and bone stress injuries and the concept of relative energy deficiency in sports, we really take a multidisciplinary approach. So as we recognize there are multiple risk factors, intrinsic components to injury, extrinsic component, nutritional components, hormonal components, it's just super helpful to have a good team that you're working with. Sports physician, endo, GYN, nutrition. Sometimes there's a need for sports psychology, the physical therapy, and the athlete-specific athletic trainer. So everybody kind of working together to optimize health for these athletes. We've actually, within the last 6 months, have started a multidisciplinary bone stress injury clinic. And so we bring together a team that really can address all these different aspects to the athlete's care. So that is all. Thank you so much for having me. I so much appreciate it.
Thank you so much, Courtney, for your time and all the information that you provided here today. So we actually got a few questions. I know some attendees are raising their hands. Please know that in order for you to ask a question, you have to email Emory MSK Radiology at gmail.com. Again, all one word, Emory MSK Radiology at gmail.com. So with that, we will go over a few questions that came in as you were doing your presentation, Courtney. So the first question is, do you see a typical ligamentous avulsion injury in this group of patients or athletes where at their age, the ligament that will be expected to fail or instead the bone fails? For example, in teenage females, do you see more ACL footprint avulsion, whereas those without a triad in the same demographic will get an ACL tear? Meaning that, do you see more avulsion type injuries instead of a ligament proper injury in this type of patients? Just because the antithesis, the attachment point of ligaments to bone is fragile?
Yeah, that's an interesting question. So kind of asking, I think I'm understanding. So asking, like, is there an increase in like tibial spine avulsion versus ACL tear in this?
Yeah, I think that overall, do you see more avulsion type of injuries, ligamentous injury in this type of patient than ligament injury themselves? For example, so in females, with this triad with energy deficiency, do you see more ACL avulsive injury than ACL injury itself? I think
that's an interesting question. I don't actually know. I would have to pay more attention to that. I hope I'm answering the question in a helpful way, but I've not necessarily thought about kind of I've always thought about that more as kind of an age related, with an increased risk of like an avulsion, tibial spine avulsion versus ACL. But I'd have to pay more attention, whether there was an energy, a relative energy deficiency component to that. But it's an interesting thought. I don't know that I can specifically say that I have noticed that, but it may be something that's seen me that I haven't seen because I haven't been thinking about it that way.
Perfect. The other one is, what is your experience with time out compliance? How often do you see these recurrent injuries?
So again, I hope I'm answering this correctly. So I think the question is that if athletes stay out for long enough, are they still having this high rate of recurrent injury? Or
how often do you see them comply with your recommendation to have a time off?
Yeah. Yeah, I would say that athletes are pretty compliant. I mean, for example, if it's a collegiate athlete and you're working with their athletic trainer and you have come up with a plan together, then for the most part, I mean, they're following that because they're working very closely with their trainer, and same from a high school standpoint. As athletes get into, if they're kind of past college and they're still serious athletes, but not kind of specifically working with an athletic trainer, then probably there's a little less kind of sticking to the exact the exact time frame, but certainly for high school and collegiate athletes, I feel like they are pretty compliant with recommendations, just because it's a team approach that's really, you know, they're being overseen by their athletic trainer too.
Right. So this is actually a question of mine. Do you see the background here?
I do, yeah.
So as you know, Courtney, as you know, when we go over cases like this,
Yeah.
perhaps, you know, one of the most widely used grading system right now, based on MRI, that we use in radiology, is the Femoral classification system, where we have 4 different grades, right? Grade 1,
Right.
periosteal, grade 2, edema in the periosteum and deep to the cortex here. Grade 3, just accentuation of the findings, and grade 4, variations of cortical changes ending up with a fracture. So as we, you know, in the past, we talked about this, right? The recommendation of time off for these injuries. For grade 1, you know, they recommend 3 weeks. For grade 2, 3 to 6 weeks.
Yeah.
Grade 3 up to 16 weeks, and grade 4, 16 or more. I think you and I have spoken before extensively about this, and based on your clinical experience, this recommendation seems to be a little too generous, perhaps, or the time off is quite extensive. Do you mind to address this, you know, in your own experience, right, in your own clinic? How much time do you usually give an athlete for a grade 1, for example, all the way up to a grade 4?
Yeah, you know, I think with a grade 1, I think it's reasonable to kind of start with that 3-week time frame. So number 1, if we're talking about tibial stress injuries, if there's pain with walking, they're going to be in a boot for a period of time. And obviously, as you go up through the higher grades, they're going to be immobilized in a boot. But for grade 1s, you know, talking about expectations for patients, I think 3 weeks is reasonable, and then you want to really clinically reassess. And then for grades 2 and 3, you know, I would start with, I mean, specifically for grade 2, you know, I would probably start with talking with athletes about 6 weeks. And then you can, you know, maybe see them back at the 3-week mark, see how they're doing, and kind of get a sense of how much are they responding. And then, you know, I usually always talk with people about at least 12 weeks out when you're talking about a grade 4. But oftentimes, again, this can be even 12 weeks, 6 weeks in a boot, and then kind of gradually getting out of the boot. And so there's not, it's hard when you're talking with athletes, because if you give them a specific, you know, time where you say, okay, 12 weeks, then they're holding on to 12 weeks. And so if they get to 12 weeks and they're still hurting, or you have a concern of some kind, then it feels sort of like a failure. So I would say that usually I'm not talking with athletes as much about kind of that 16-week time frame, but usually at least 12 weeks for the higher grade injuries, to kind of start to get a sense of when do we think we might be able to get you back to running. Is that helpful?
Absolutely. Based on your clinical experience, how many of those patients that present with a grade 4 or cortical fracture, you know, when you recommend them to be off 12 weeks at least, and then you follow with them in the clinic, what percentage of those patients you think go on to full resolution of the cortical fracture within that period of time, 12 weeks?
Yeah, I mean, I would say that I feel like I usually see kind of more complicated cases, in which there are components to relative energy deficiency that actually can kind of delay healing to some degree. And so I don't know if I'm kind of exactly answering your question, but, you know, it's interesting because sometimes it takes some time to get the athlete on board that there may be more to it than just a bone stress injury, you know, that there may be a vitamin D component, or there may be an energy deficit component. So sometimes I'll see athletes who have energy deficits who don't want to address that initially. And so that can kind of delay the healing some. But I don't know percentage wise what I would say about, you know, at 12 weeks, a grade 4, they're ready to go. Certainly I wouldn't take somebody with a grade 4 and at 12 weeks kind of unsupervised, just say, okay, well, here's your return to running program. Just kind of go and let me know if you're hurting. But 12 weeks is more, do we have them work with a PT group that has, oh gosh, I'm blanking on, where they can kind of gradually increase the amount of weight they're putting on the treadmill, that kind of thing. Are they starting to do kind of more weight bearing activities? So 12 weeks is kind of when you may start to get people back to things, see if they're hurting or not hurting. And that kind of helps you know how quickly you can move forward with them.
Perfect. And just one last question, and thank you so much for being so kind of being here today and answering all these questions and your presentation. Some radiologists, in our field are trying to basically generalize this classification system for any type of bone injury in the body, right? So this is specifically designed in the literature for medial tibial stress syndrome. However, some of the radiologists that we interact with nationwide, there's a push, to generalize this classification system for any bone injury in the body. Will you be okay overall, as a clinician, to have a generalized system like this for any type of bone injury, regardless if it's in the tibia or in the fibula? You think that classification system like this makes sense for you as a clinician and referring physician, for a radiologist to say grade 1, grade 2, or do you prefer that a radiologist is more descriptive?
Gosh, that's a good question. I'd probably have to think about that a little bit more.
Because some of us sometimes we don't grade things. We say there's periosteal edema, there's meridema here and there, there's cortical remodeling. I know that we have worked a system within Emory to grade this, this injuries, right? So in the body of the report, we are very restrictive, but in the impression we say grade 2 injury. Do you think it will be easier overall for clinicians, referring clinicians, for radiology to be restrictive without using any grading system? Or do you think that a system like this being generalized to any bone injury in the body will make more clinical sense?
Yeah, I don't know 100% how I feel about it right now. Like I say, I think I'd have to kind of see how that would play out. I think that if there was a very useful universal system that like was very helpful at explaining what was going on with bone stress injuries throughout the body, it just seems like there's actually there's really variability depending on where the bone stress injury is. Even the location can change kind of the level of concern. And so I'm just trying to think about that a little. I don't know. I'd have to give it more thought. Maybe we can talk about it some more. I don't have a great response to that right now.
No, absolutely. Thank you so much for your time. So this will conclude our presentation today. Again, if you want to have access to the presentation, if you go to YouTube and Google MSK Radiology, you'll find the channel there, and this presentation will be available in the next few hours. This presentation, again, available in the YouTube MSK channel. It's free of charge, on demand for everyone. So thank you so much for everyone. Have a great day. Stay safe, and thank you again.
Thanks, Felix. Thanks, everybody.
Absolutely. Thank you.